Hello, my name is Avronia Marcus. I'm a third-year medical student from Midwestern University in Glendale, Arizona, and today I'm presenting a case of COVID-induced rhabdomyolysis. So we have a 39-year-old male patient who came in with a history of asthma, a recent COVID infection that led to pneumonia and required hospitalization, and he currently presented with a worsening generalized weakness. On physical exam of the patient, on the extremities, we noted +1 bilateral lower extremity edema, upper extremity edema that was +3. It was pitting edema. The skin was very taut in the upper extremities, and the left upper extremities had more swelling than the upper right extremities. However, they both were very edematous. On examining the skin, we found a midline lower abdominal macular erythematous blanching rash, and the lower extremities both were erythematous with a non-blanching rash. On a neuro exam, we found strength was 3 out of 5 bilaterally in the upper and lower large muscle groups in the extremities. Sensation to light touch was intact, however, grip strength was a 3 out of 5. When we drew labs for this patient, we did find lactic acidosis as well as severe electrolyte abnormalities. So white blood counts, as you can see, were very high. Sodium was low. Potassium levels were high. Glucose was high. Ionized calcium levels were low. BUN was high. BUN creatinine ratio was also high. Transaminases were high. CK was elevated, CRP was elevated, and procalcitonin was also elevated. And so when we got these labs and we saw the hyperkalemia as well as the hypocalcemia, there was also hyperphosphatemia, all these things, we were kind of thinking some kind of muscle damage. And so when we did more research, we found that in someone who presents with common COVID-19 symptoms, such as shortness of breath, fever, fatigue, the usual symptoms that we've seen, for the past year and a half in everybody, if they also have high CK levels and there's some evident weakness of the extremities, then we should consider myositis and more specifically rhabdomyolysis. So this patient, they came in, he had all of these things, and for these reasons, we did believe that he might be suffering from rhabdomyolysis as a complication of COVID-19. And the reason we thought that, like I said, we researched it first and we found that there had been 23 other reported cases, all of which had tested positive for COVID-19 and showed some degree of myositis, whether it was rhabdomyolysis or dermatomyositis. And so we kind of chose to, pursue that diagnosis and follow it closely. And so, like I said, recent findings have linked a connection between COVID and myositis, and that we believe can be attributed to tissue hypoxia or direct myocyte damage. And rhabdomyolysis, as we know, is a condition that describes the dissipation of injured muscles and then the release of these muscles into the blood. COVID-19 wouldn't be the first virus that has caused some kind of muscle damage. As we know, viral infections like influenza, Coxsackie virus, and HIV have also been linked to rhabdomyolysis, which, again, shows up same way. It's more of, lower extremity weakness, there's myalgia, high CK levels, and all, same pattern that we saw in this patient. Like I mentioned, the hyperkalemia and the hypocalcemia as well. And so because, CK and myoglobin levels can sometimes go unchecked, we think it's very important to monitor, rhabdomyolysis. It can also go unchecked. And so, but once you do kind of suspect that it is rhabdo or some kind of myositis, it should be monitored very closely, so it doesn't lead to further complications such as compartment syndrome, for example, as a sequelae. And so that's what we did with this patient. We monitored him very closely, and then he actually ended up getting transferred out to St. Joseph's after we got our neuroconsult and such. So this was our patient. These are some references. We thought it was a very interesting case, and if you have any questions, feel free to email any of us. Thank you.